fairly easily. The superior articulating facets are more rocking chair shaped because the occipital condyles are going to sit in it, so we can say yes in this culture. So it's like if you were to use a rocking chair on dirt or sand, you would get those divots that match the rocking part. So those elongated facets are going to be where the skull rocks back and forth, so we can say yes in this culture. The inferior articulating facets are rounder, again, because they allow pivoting with the axis. Okay, so those shapes are going to look very different from each other because they have different movement capacities. So our yes side in this culture, because in India that actually means no. Kind of weird. C2, that is our axis. So that is going to allow your head to rotate on its axis. So you're going to have the atlas sit and rotate around the axis back and forth so we can shake our head side to side or left and right. The point that it pivots or rotates around is called the DINS or the ontonoid process. Again, it's called the ontonoid process because somebody thought it looked like a big tooth, like dont means tooth. We've learned that orthodontist, periodontal disease, that kind of fun stuff. So somebody thought it looked like one big lone tooth. I guess they probably knew that one lady that's always kind of creepy that has like the one tooth and she can still chew steak even though she has one tooth. Those people worry me because it's like, how can you not stab yourself while you're chewing your steak with your one big tooth? It's skill or something. But you have that guy that we're going to rotate around so we can say no. So that's the couple of them working together. The atlas, that is going to rotate. It's going to have this little strap down so it doesn't fling off anywhere and rotate around the axis so we can say no in this culture. Thoracic vertebrae T1 through T12. In the book, it describes it as having a heart-shaped body. Again, in anatomy, imagination is very important. Okay, I guess it almost looks like a heart, like if you buy your conversation heart candies at Dollar Tree, so they're not right heart-shaped. They don't say normal stuff on them. They're still delicious, though, right? Conversation hearts, it is the season. I like the white ones. It's the candy cigarettes. And the yellow ones. Okay? So those little guys, heart-ish shaped bodies. They're going to have costal facets. Costal facets, again, attached to your ribs. They're the only ones with costal facets because they're the only ones that articulate with the ribs, which is why we have 12 pairs of ribs, because we have 12 thoracic vertebrae. So when you're looking at other mammals or birds or what have you, you know how many thoracic vertebrae they have by counting how many pairs of ribs they have, because every single rib has to attach to a thoracic vertebrae. If it doesn't have a rib, it's not a thoracic vertebrae. So we got 12 pairs, so 12 thoracics. Now they're going to increase in size. This is true for all vertebrae. They're going to get bigger as we go down because we're holding more and more of the body weight. So T2 is bigger than T1 because it's holding T1 and everything T1 is holding. T3 is bigger than T2 because it's holding T2 and everything T2 is holding. So as we go down, each vertebrae gets bigger and bigger. Our largest individual vertebrae is L5, okay, because it's holding everything above L5. So he's a big stressed out dude. And then, of course, the sacrum and coccyx fuse together, so they don't have to be individually big because they're a big chunk that helps to distribute that body weight. So as we go down, we get bigger and bigger and bigger. Now, with our thoracic vertebrae, we're the only mammals that have our thoracic vertebrae pointing inferiorly because we're the only mammals that walk on two legs. So we don't have the big muscles necessary to support our upper body to walk on all fours. So we don't need any bones to put those big old muscles on. So they're going to point downwards. So that allows you to identify if you're out, hiking in the woods and you find a thoracic vertebrae and the spinous process is pointing down, you call the cops because you just found somebody. If it points straight up, you don't have to tell anybody because that's like a deer, okay, or a cow or something. So that makes them pretty unique for humans compared to the other mammals out there. So look at that. It's a lovely thoracic vertebrae. So there's these little costal facets so they can hook up with the ribs. And then our heart-shaped body, if you squint, it kind of looks like a heart. Lumbar vertebrae, L1 through L5. It does the small of the back. That's why when you get chairs, sometimes they have lumbar support or people get lumbar pillows and stuff. That's your lower back. And they're going to receive the most stress because they're picking up everything above them. So if you're L5, you're holding basically everything above the belly button. So if you power lift 500 pounds, L5 hates you. Okay? It's sitting there going, I'm going to die, because it's dealing with all of that weight being pressed upon it. So these guys will have a huge body. Again, the vertebral body's job is to support body weight, transmit body weight. So it's going to be much, much larger in these guys. We also are going to have large, stumpy spinous processes. Some of them are about as wide as they are tall. And these stumpy processes give us more surface area to attach muscles to, because we've got back muscles that attach to them, ab muscles that attach to back muscles that attach to them. So if you've ever had exercise classes, it's usually abs and backs. You don't just do abs because you can't have abasteel with back and flab. They work with each other because that's their anchor point, those lumbar vertebrae. So lots of muscle attachment for those guys. So we need space to attach to them. All right, there's our moose with our big old wide spinous process and our big body for transmitting the body weight. And this picture does show those curvatures we talked about yesterday. So again, the primary curvatures, the thoracic and the sacral, both curve anteriorly, both curve forward. The cervical and the lumbar both curve posteriorly, so making that S shape to it. So those lumbars have a really big curve associated with them. The sacrum, so they're going to fuse together to be one big chunk, but originally started off as 5 separate ones, so S1 through S5. They are going to start fusing somewhere around puberty. So a lot of times in the books, they'll say approximately 16, and that's because by 16, most people have started puberty unless you're anorexic or starving or having health concerns. But obviously, this is going to vary. If you're a girl and you started your period at 11, your sacrum started fusing at 11 because that's when you hit 13. If you didn't start your period until 16, it's not going to start fusing until 16. So it all depends on the individual's conditioning. When did that kid hit puberty? That's when we're going to start seeing those big bone changes between the fusion rates and growth and so forth. Most people, it's fused by 25. Now, again, if you had that late start, it's going to take a little bit longer. It's not like you started fusing at 16 and it has to rush to get to 25, or you started at 11 and it's slowly going to reach. It usually gets to there based on your puberty rates, your hormone rates and growth and so forth. So some people, it may fuse earlier, especially if they started puberty earlier. It may fuse a little later if they started puberty a little later. The latest they have found is 30. Again, those are usually the really severe, the people who were hiding in attics in World War II and they came out all stick-figured and distraught. They didn't get a lot of nutrients. They had a lot of developmental and body delays that permanently changed their bodies and skeletons. So 30 if you've had health issues, if you're not going through and ossifying like you're supposed to. Look, it's a sacrum. It's like we've seen it somewhere before. All right, your coccyx, your wee little tailbone, CO1 through CO4. Now, some people will get a fifth. It doesn't do anything for you. It's just a happy accident. It's an extra, kind of like having a sesamoid bone or a sutural bone. So it doesn't really do a whole lot for you. And of course, they're going to fuse together. They're going to start fusing once the sacrum is done fusing. So usually we say 26, but if your sacrum was fused by 20 because you started puberty at 11, then your tailbone's not going to sit and wait for 4 years. It's going to go ahead and start. So somewhere by 26, we should start that fusion rates, and it's going to fuse fairly easily. Now, if you get really old, you're in your 70s, 80s, it might fuse to the sacrum because why not? It's not doing anything. It's just sitting there. Might as well attach to the guy above it. So again, elderly people may just have one chunk down there instead of 2 chunks like a younger person. Now, it is nearly useless. Okay, so we can't do anything with it. It's just there for attachment of ligaments associated with the spinal cord to help anchor things in place. There's no muscle associated with it, so you couldn't wag it. If you've ever watched Shallow Hal, anybody watch Shallow Hal? If you haven't, it's probably canceled by now because it offends everybody. It's like Mel Brooks. Great movies could not be made today because people would whine about them. But there's a scene in Shallow Hal where a guy has a tail and he wags it because he's nervous. It's like, yeah, that's not biologically accurate. You couldn't wag it even if you wanted to. We don't have the muscles to do that because we've lost them over the eons of development. Now, with infants, sometimes they are born with a long coccyx. It can be visible. They can have a tail. Nowadays, they tend to cut those things off because PE sucks enough without having a tail, because that's one thing that's going to get you picked on in school. Again, the tail's useless. It doesn't wag. It just sits there. It's just bone and skin. So it causes more of a hindrance than anything. So they are usually going to dock them just like Dobermans to get rid of it as quick as possible. I think in the book there's a picture of a kid with a tail, but you could probably Googly that thing. There are pictures of like people from the 1800s because they didn't used to do as much things like docking people's tails back then, so you can find those. But again, since there's no muscles associated with it, it's not going to do any good to keep it around. Now, sometimes you can be born with the coccyx not long enough to be visible outside, so you don't actually see a tail, but they are longer than normal. And those individuals, they may have issues with their gait. So if you go into certain physical therapies, if you go into massage therapy, they have different massage techniques for people who have long coccyxes to help alleviate stress, because if it's bigger than it should be, it's going to affect the ligaments and tendons in that area. So the more you walk, it might actually cause irritation and inflammation. So some people may have very bad lower back pain if they have swelling and so forth around this area. So it's something that you may come across with certain types of physical therapies and release kind of things, whether it's physical therapy through, medical wise or massage therapy, things like that. So sometimes you'll see that pop up. So it just means that guy's too big, even though it gets fused and stuck inside. The parts of our anatomy, so we have 3 different functions of the vertebrae. So each part of their anatomy is going to have a different function associated with it. So we have 3 of those. We have the vertebral body, whose job is to support the body weight. We have the vertebral arch, whose job is to protect the spinal cord. And we've got the articular processes, whose job is to provide the joints so we can have movement. So the vertebral body, that's just the big solid portion of the vertebrae, makes up the biggest bulk of the vertebrae. And again, it's going to be solid to deal with that weight transmission from one to the other. They are going to be tied down together by lots of ligaments. We don't want them to shift, because if they shift too far, they'll sever your spinal cord, and that's going to be bad for you. But if they shift even a little bit, it can change weight transference. It can be very painful, very awkward, limit range of motion. They will be separated from each other by intervertebral discs. So we'll get to these more next week when we get to the joint chapter. But these are just really kind of thick padding, similar to the soles of your shoe, to help cushion between those so they don't bang into each other or fuse into each other. The vertebral arch, which is a delicate bony arch that is going to surround and protect the spinal cord, which to me kind of seems odd. You would think the spinal cord is kind of important, it's kind of a big deal. You would want to have a lot of protection around it. It actually is a very thin little protection. So you're like, okay, you go with that. So again, parts of our vertebral arch, we have the pedicels, they form the walls or the sides of the vertebral arch. We have the lamina that forms the roof of the vertebral arch. Where the lamina come together, we're going to have the spinous process for muscle attachment. We're going to have the transverse processes where the pedicels and the lamina come together. They kind of form an overhang, again, for muscle attachment, and in the case of the thoracic vertebrae, rib attachment. So all together, they're going to form the vertebral arch, and in the center is going to be the vertebral foramen. That is where the spinal cord sits. So when you look at those vertebrae in lab, that one little small area is where your spinal cord is sitting. Even though it is very important, obviously, you're not going to function properly if you damage it. It's a very tiny structure. It's only a ½ an inch thick at its largest. So just because it's small doesn't mean that it's not important. So that's one of those cases. It's actually kind of tiny compared to some of those other structures in the body. Our articular processes, we have the superior articular facet and the inferior articular facet. They're found also at the junctions of the lamina and the pedicels, usually just to the side, or modifications off of the transverse processes. They allow you to touch your toes. They allow for movement. So the superior articulating facet of one vertebrae is going to articulate with the inferior articular facet of the vertebrae above it. So when you go to touch your toes, they slide past so you can touch your toes. When you stand up, they slide past so you can straighten back up. And of course, in the case of the cervical, they can slide past each other a little bit more so you can look at the sky. So that movement that we see or associate with the spinal column is due to those processes. So if we want to twist side to side, they do shift side to side as well. So we have limited range of motion because if you go too far, the ligaments will prevent that and the transverse processes will prevent that as well. Our thoracic cage, so it is going to be made by the thoracic vertebrae in the back. That's why it's called the thoracic cage. The ribs to the side and the sternum to the front. And this cage, again, is going to be a protective boundary around the organs within the thoracic cavity. Yes, sir?
I heard another student from a different class, they corrected me and said it was the thoracic cavity. Is that incorrect?
That is incorrect. The cavity is the space in the cage.
Okay.
Kind of like when you have a cage where the animal is there. The animal isn't in the cage bars, it's in the cavity that's in the cage.
Okay.
Depends on which part that student was talking about versus what part you were talking about. So the cage is the bone. The cavity is the space inside where the organs are located.
Okay.
So the cage is going to help, again, protect your heart, going to help protect your lungs, your esophagus, your trachea, everything that's in the thoracic cavity there. Now, even though it's protective, it needs to be flexible because you could have a complete bony plate all the way around, completely surrounding those organs. Yes, they're going to be very protected, but your lungs can't function if the ribs can't expand. You wouldn't be able to breathe properly. You'd be able to breathe a little bit. So it'd be like little huffy breaths. It would not be very efficient to keep our body going in the way our body needs to go. So we have to be flexible so we can expand the cage so our lungs can expand and we can suck air in. We can constrict the cage to squeeze the lungs and the space within to force the air out. So we need it to be flexible so we can breathe properly. Now, it is flexible enough that if you need to have surgery in your thoracic cavity, you don't always have to do bone cutting. You can kind of go in and squeeze. They make these little tools that are kind of like a car jack that you put between the ribs and crank them open and the ribs will spread, rib spreaders. So you can get in and get out if you need to without causing any kind of bone damage or anything like that. So that can be pretty darn handy. If you have to get a chest tube because you have too much fluid around your lungs because of an injury or irritation or what have you, they just spread your ribs, stick a tube in, drain you. And then you have this like little briefcase box filled with fluid coming from your lung tissue. It's like, me and my fluid box. So they can do that without any kind of surgery. Unfortunately, sometimes it's an emergency case, so they do it without any kind of pain killing either. Awkward. Now, if we do have to get in, we have to get in and do a full heart issue, not just a little look from the side. We, of course, can cut through them. Since the sternum, since the ribs are flat bones, it's very quick to heal because they don't have to do a whole lot of maintenance. They're small, so you don't have to do a whole lot of building with those little guys. So you can cut through. If they break, they heal fairly fast. So with broken ribs, a lot of times they just set them and they can tell the patient, hey, don't move a lot. Don't twist, easy breathing, stuff like that. It's going to hurt if you move too much, but they can heal without a cast. If severe, they may do binding. Okay, so there's like a soft tissue back brace to make sure you don't wiggle and move too much. If they do have to do a big major chest crack open for like open heart surgery or something, they'll cut through the middle of the sternum. That's because the sternum is more stable than the ribs, and so it's easier to tie those back together to make sure that we stay closed. And when they tie those back together, they usually use stuff like piano wire, but sterilized. That's one of the funny things about surgery. It's like you can buy it at Lowe's, but if it's sterilized, you get to charge double for it because it goes in the body, right? It's like self-tapping screws are like 2 cents each at Lowe's, $50 each in the hospital. Okay, so sterilization apparently is a really big deal. But they'll use sterilized wire, usually the gauge that we see, piano wire, to wire the sternum back together to keep it close if necessary. So your ribs, we got 12 pairs of ribs, and of course, based on who they attach, where they attach, they get their different names. So we've got our vertebral sternal ribs, the vertebrae in the back to the sternum in the front. So we've got rib 1 attaching to the manubrium, ribs 2 through 7 attaching to the body of the sternum. And again, this is why sometimes the book calls them true ribs, because they attach directly to the sternum. We don't use true ribs, like we don't use hip bone or knee bone or leg bone, because we're adults and we use big people ribs. Vertebral chondral ribs, vertebrae in the back, cartilage in the front. So they do not connect directly to the sternum. So that's where they get the falls from, because they don't go directly there. So again, the cartilage of 10 is going to fuse to the cartilage of 9. 9 is going to fuse to the cartilage of 8. 8 is going to fuse to the cartilage of 7. And it's 7 that goes and touches the sternum. Vertebral ribs, vertebrae in the back, nothing in the front. So that's why they're sometimes called floating or floater ribs. Again, we don't use that term. So they're going to attach muscles to them, so they are necessary for muscle attachment. They can also be used for protection. They don't form a complete cage, but if you were trying to be shaped from the back, it would still deflect a knife or something. So they are still protective, just not as complete as the big boys above them. So there's our cage holding all our bits and pieces in. So again, 1 through 7 directly to the sternum, and then 10 to 9, 9 to 8, 8 to 7, and it's 7 that goes to the sternum. Okay? And then there's our little guys in the back going, hey, me too. So those are those vertebral ribs. Your sternum, your breastbone, when you're born, it starts off as anywhere between 6 to 10 fusion centers. So a baby might have 10 little sternums sitting in there, fusing together, ossifying together. Now, the big 3 pieces, the big boys, manubrium body and xiphoid process, do not start fusing until 25. So if you're still in your teens, you have 3 completely separate pieces of your sternum held together by connective tissues. And then they're going to start fusing around 25. So our first guy, the top guy, is the manubrium. So he is triangle shaped. So you can kind of imagine a triangle with the corners cut. That's a little bit closer to the shape there. And of course, manubrium comes from the word that means mouth structure. So we actually see jellyfish and grasshoppers and a whole bunch of other animals have a manubrium. So it's the one closest to your mouth. It is going to attach to the clavicle, as we mentioned in lab. That is the only attachment between the axillary skeleton and the upper appendages. So that's going to keep your arms from falling off your bodies by attaching the clavicle to the manubrium. And then tucked up under there is going to be the first set of ribs, which look kind of funky because they are so short and curved. That attachment point is built a little different than the rest of the rib attachment points because where it's sitting, it can't flex as much because the clavicles are right there. So they're not going to be as helpful with the breathing. Your body, the biggest part of the sternum, is going to connect to ribs 2 through 7. And of course, that cartilage is going to allow the flexibility of the movement so we can breathe. And then we have our wee little xiphoid process, the littlest guy. It does not have any ribs associated with it. It's just going to attach to muscle. So it attaches to your diaphragm, your breathing muscle on the inside, and the rectus abdominis, your 6-pack abs, which actually are 8-packs, on your tummy, so you can touch your toes. So that's going to attach to your xiphoid process. Now, this little guy is the last one to fuse. It fuses about 40. Because of that, this one is kind of our kind of flag what was it in the sand, line in the sand. So we often use 40 as our break between young and old. Even though the closer you get to 40, you realize it's really not that helpful. When you get closer to 40, it won't be so bad. Okay? It's just like you're 20, just a lot more in the morning. Okay. So what happens younger than 40, unfused xiphoid process, that's labeled as young in a lot of your textbooks and such. If your xiphoid process is fused, you're over 40, that's midway for the average human being, so that's been considered old. But again, it's all in your mind. If you feel young, then you're as young as you feel. I'm a zombie already. All right, so it's one of those things that this is just our arbitrary line in the sand between the youngs and the olds. Nothing personal. That. Now, this little guy we talked about can be problematic because it can break off during CPR. So when you get trained to do CPR, they usually tell you to be mindful of this little guy. Don't be right above it because you'll increase the chance of breaking that little one. Now, of course, when you do CPR, you do it correctly, the odds are you're going to break something, usually ribs. Bruising at the least, breaking often happens. So if you get CPR done to you, you always go to the hospital to check out to see if any ribs are broken so they're set properly so you don't have health issues. This little guy can cause a lot of problems because if it breaks off, the diaphragm is attached to it, your breathing muscle, so that's going to affect your ability to breathe. So you might feel really short of breath even though you're alive. It's like, I can't take a deep breath. It's that little guy's flopping. It's not going to work out too well for you. And when it breaks off, it tends to go straight down into the liver because that's right next to that little guy. And of course, if it damages the liver, massive internal bleeding, that kind of ruins your day. So you want to make sure that you get this one fixed up. And of course, healing, it depends. If you break it off under the age of 40, so you're a young person and you break the xiphoid process, it may take surgery to repair it and attach it because if it kills the ossification centers during that break, it's never going to fully ossify properly like it's supposed to. If it breaks after 40, it may heal, but it just depends on how severe the break was and where it ended up. Okay, so you typically have to go and get this one reattached at some point so it could heal properly for those individuals. So when we start looking at the anatomage table, as I mentioned, we're probably not going to show you this chick because she's weird. The one lady that I don't show, she has a forked xiphoid process, which is freaky as hell because when you look at her skeleton, she has a fork down there. It's like, what were you doing to get that? But some people, instead of being a little point that tapers, it's a fork. Odd, because you're going to have weirdness with people. Okay, so we'll start to see that when we start looking at the anatomage. We've got the old guy that we'll use for most of the stuff. The muscle dude, we had to use a big boy, so he'd have muscles to look at. He's homegrown. He was an inmate in a Texas prison, and he was put to death for murder. Go us. Now he's in the anatomage table. So we'll see him for our muscles when we get to that in the anatomage. He also has one testicle, which is really weird. We're going to guess it was a prison accident. So I don't use him for the male reproductive because he's missing it. So you actually see it's like, look at him, one testicle, and then the sheet goes over like, okay, stop looking. But it's kind of kooky. Ooh, conditions. So, of course, when we look at the curvatures, for us to have normal transmission of body weight from top to bottom, those curves have to be in the right position the right way. If the curves are off, it's going to affect our ability to move. It's going to affect our ability to transmit body weight. So we may have issues with lifting heavy things. It can affect our breathing if it's off on our thoracic area. So we need to make sure the curves are correct. So our first one is scoliosis, so an abnormal lateral curvature. That's why it's abnormal. All of the other guys, again, curve forward or backwards, right? They make the C shape facing forward or they pull towards the S facing backwards. Nobody goes to the side. So they shouldn't be there at all. That completely alters the ability for this spinal column to do its job of transmitting body weight and protecting and all that kind of stuff. It typically happens in the thoracic vertebrae. Most people have an issue there. So it can be mild. It could be just a slight tilt that can be weird looking, but doesn't cause a whole lot of harm or a lot of loss of functionality. With severe, it could actually extend down into the lumbar vertebrae. So our little drawing up there, hers is kind of severe. You can see where it's involving the thoracic vertebrae as well as the first couple of lumbar vertebrae because the thoracic went so far to the side. This is the one that, if you remember, usually in PE in elementary school, they would have you touch your toes and they'd watch you. Or your pediatrician would do the same thing, touch your toes and they watch you. It's not to be creepy. When you touch your toes, your spinous processes poke out a little bit more, so it's easier to see the curves. So they could see if you were misaligned. Also, if you rub your finger down somebody's back, if they have scoliosis, it's going to do a lateral curve. They don't usually do that too much unless they suspect it, because then they can run their fingers. And of course, anytime you see this, that's not right, right? You know, mama comes in the room, excuse me, you're like, oh, here it comes. Okay? We don't want this. Lateral curvatures are not a good thing for the spinal column. If we do repairs, we can do physical therapy to try to straighten you back up, you know, special back braces, things like that. If we have to do surgery, it's not going to be done until you're done growing. If they do it too soon, it can disrupt your ossification centers and prevent you from growth. And they don't want to stunt you to fix your spinal column problems. So usually this is going to be late teens, early 20s. When they do the surgery, they basically separate you and restack you like a bunch of Jenga blocks. So they'll stack you where you're straight instead of side to side curving. And then they'll put rods on either side so your vertebrae don't shift back to the left or right, keeping you nice and straight. And those rods will be with you for the rest of your life so you don't accidentally go the wrong way. Our kyphosis. Kyphosis is an exaggerated thoracic curvature. So on the street, this is usually called hunchback, or somebody's got a hump. So this is often due to poor posture. Kyphosis and lordosis is most often due to poor posture. In the case of kyphosis, it could either because you'll see this a lot with tall people, and some, for whatever reason, some tall people like to slump so they can be closer to the rest of us mortals. So they end up having a little hunch to them. You see this with really tall people. We also have the issue of kyphosis happen if you have a lot of weight in your upper body. So we'll see this a lot with women who are well endowed. This is why they make bras that are supportive instead of eye patches, right? It's okay to admit it. Some girls wear eye patches to the beach. It's my bikini. You're like, that is an eye patch. You just got 2 eye covers. That's not going to support you. So if you wear those little stringy things, you're going to have a hump. I hope you like it. It should be sexy. So you got to have the support to pull things up. If your muscles can't do it, the bra's got to do it. So that's why you have the big supported runs forward. The bigger you are, the more support you're going to need, so you don't get a hump. Nobody wants a hump, because it affects everything. Gonna ache, gonna hurt, gonna cause problems. And eventually it can cause issues with breathing. If you're too hunched over, you're not gonna be able to expand your chest properly. So you can't breathe well. Lordosis. This is an exaggerated lumbar curvature. So lordosis, lumbar, both start with an L. This on the street is known as swayback. Okay, so this is also often attributed to weight distribution. So your belly's too big and you push your belly forward. So we see this a lot with pregnant women, because a lot of pregnant women like to walk with their belly forward because, I don't know, you've got to use it to knock over people while you're walking. But that's going to cause issues to your spinal column. Guys can get it too. Sometimes it's associated with pot belly. Sometimes it's just really bad posture. This is also why if you've been pregnant, a lot of times your OBGYN stresses having really good posture. And that's not because they're the posture bullies. When you're pregnant, you release relaxin. We'll talk more about this next week. The job of relaxin is to loosen up cartilaginous joints so your big-headed baby can get out easier. But it targets all cartilage in the body. So if we loosen up the cartilage of the vertebral column and you slump or push your belly out too much, you can end up causing that lordosis or causing that kyphosis. So it's important to have good posture so you don't misalign your vertebrae while they're extra flexible. Once you're done with the pregnancy and that hormone leaves the body, they'll firm back up. So if you mess up your posture while you're pregnant, it can become a permanent issue for your body. This is also why sometimes pregnant women's feet grow. Right? We've always said, oh, your feet are going to grow. They're not growing, they're spreading. Okay, so when you're pregnant, you need to have good supportive shoes. If you're barefoot and pregnant, there's nobody to support your arch, and your arches will start falling because, again, cartilage keeping everybody together. So if they start falling, it causes your foot to spread. So it's not really growing, it's spreading. Like cookies don't grow in the oven, they spread in the oven. And then you'd have to buy new shoes. Okay? And depending on how big your feet were to begin with, you may not want to get new shoes, right? That was my fear. More at 9.5. I don't need any bigger shoes, or I'm going to have to be shopping with the drag queen just to find somebody my size. Because 9.5, it's already hard to find shoes. So it's terrifying. So wear good supportive shoes. You won't have to worry about your feet growing because of that pregnancy. If you have good posture, you don't have to worry about causing sway back or hunchback whenever you're standing up properly. Yes, sir.
You said the scoliosis can also travel into the top part of the spine?
It can go, it's usually thoracic, but it can travel down to the lumbar.
Down to the lumbar, okay.
Yeah, so those are the two main areas that get it. So here's some examples. Ooh, this one just looks painful. Like you want to rub some lotion on it because she's so stretched out. I say she, I don't know, I can't tell. But major kyphosis. So skin uncomfortable on this individual probably. So you have skin issues, could tear. This severe hunch right here is going to prevent proper expansion of the rib cage. So it's going to affect their breathing, going to affect their posture, probably a lot of back pain and can't lift heavy things, that kind of stuff. Here's a dude with some lordosis going on. So no, it's a guy. So it kind of pops out kind of funny. There's lots of pictures. Lately, they've been popping up because if you can see women who have worn corsets all their life, it causes lordosis because it sucks everything towards your waist, and it will cause a permanent change in that curvature there. So pictures of women who have worn corsets with their corsets off, you can see a huge sway back. That's what really caused a lot of issues with sway back. That's the unfortunate thing with corsets. They alter your organ placement. They alter your bone structure. So if you wear corsets for too long, too frequently, it'll get to the point you can't take it off comfortably, because once you remove that support, that spinal column that's now overly curved can't deal with the weight that's above it. So it tends to snap you. So you have to, if it starts causing changes to your skeleton, you usually have to keep doing it. Because you're not going to be able to support your body weight anymore because of the way that corset has done the support for you. So your body gets weaker with corsets. And there's a chick with scoliosis. This is probably her pre-operation shot. So we can definitely see she has a severe case, a big lateral curve right there in the thoracic region into the lumbar. Hers is even going to cause skin issues because with the skin tucked up under the scapula, that's going to cause rubbing, and you can end up with bed sores there, decubitus ulcers there. So you can have skin problems, which is kind of the extreme end of things. of these conditions. So this was probably before she got surgery to get restacked and barred up a little bit. Spinal bifida, this is a congenital defect. So if you don't got it, you're not going to get it. So it's something you are born with. So this is where the vertebral column, you'll have one or more of the vertebral arches is incomplete. So what happens? During embryological development, your spinal cord starts off on the outside of your body. It's a little weird. It comes from the same layer the skin does. It's kooky. And what happens during fetal development, at a certain point, this neural tube dives into the body and gets covered by skin and connective tissue, kind of like dipping a taco in the tortilla covers it up as it goes down. So if you cover it up with that connective tissue, that's going to keep the spinal cord protected, but it also keeps the spinal cord in place. The spinal cord, like the brain, grows very fast in the beginning. It stops growing at the age of 4. So if we're caged by that vertebral arch, we can't expand too much. We're going to be protected, and we're going to keep growth pretty constant. If you don't have an arch to cover it up, that spinal cord could actually bubble up. It can grow too quickly because there's no boundaries, and you'll get these bubbles of spinal cord. If it's just 1 or 2, if it's pretty mild, that bubble can be surgically negated. They'll do surgery to the baby as soon as they're born, sometimes before they're born, and they'll rebuild the arches and then either remove excess spinal cord tissue or stuff it all in there and hope for the best. If it's really severe, it's going to be fatal or cause major problems for that offspring. Your book in chapter 13 shows a case of spinal bifida because that's when they're talking about the spinal cord. So in some cases, it's so severe, you get this huge bubble on the outside of the baby that is their spinal cord. So it looks like this weird red irritated mass. So again, we can correct with surgery if we catch it in time, if it's really mild. But if it's really severe, you could die during delivery. These kids always have to be delivered by C-section because shoving that through a birth canal could bump it around, which would cause more damage to the spinal cord. And if they survive the delivery, they may die within a few hours to days because the neural tissue is unprotected, which means they could get infected. It can cause a lot of issues. And of course, when it swells, it presses on nerves. It affects bone structures, muscle structures. It causes a lot of problems. Again, it's one of those reasons we do that 5-month sonogram. Everyone always assumes the 5-month sonogram is so you can pick names. It's so you can see if your kid has major problems like spinal bifida, or if they don't have a brain, or if they're missing parts, if their intestines are on the outside of their body, stuff like that. So you need to know that. That way you can have a successful delivery. So even if you want to be one of those people that squats in the wood with a stick to have your kid, there's those people. I personally wanted somebody else to clean up my afterbirth. I didn't want to have to dig a hole and bury it or something. But if you're going to do birthing at home in a swimming pool, because you know it's going to float around you. Whatever was outside, it's going to float around you. Anywho, you want to make sure that your baby's safe to do that, because if your kid has spinal bifida or major health concerns and you do a home delivery, you're dooming that child to death. So you do need to have that 5-month sonogram. Even if you go midwife the whole time, you got to go to the doctor at least once for that sonogram to make sure everything's healthy as it can be before that delivery. Laminectomy, this is when you remove the lamina, because tomi means to cut, and lamina is the lamina, so the roof of the vertebral arch. Now, when you do this, you're already an adult, your spinal cord's already done growing, so you're not going to develop something like a bubble like you would see with spinal bifida. This is due to a severely ruptured disc. When that disc ruptures, it squirts out, kind of like whenever you squeeze one of those little balls and the little gunk comes out of it. That squish will press on a lot of spinal nerves, and it can cause pain, it can cause tingling, numbness, paralysis. It depends on which nerve it squishes. And a lot of times people don't want to deal with pain and numbness and paralysis. So what they can do is they can remove the lamina, which allows the spinal cord to shift away from that bulging disc or ruptured disc and alleviate the pain or alleviate the tingling or the numbness or the paralysis. Obviously, they will be vulnerable after that. You've just removed the shield off of that spinal cord. So you can't play football anymore, or contact sports, or do anything crazy because you could poke them right good in the back and sever their spinal cord with your finger if you manage to wiggle it in and get in the hole kind of thing. So you are going to be more vulnerable, but being more vulnerable is usually better than, can't move your legs or, can't feel something or it's too painful to exist kind of scenario. Big, bad, hairy questions. Partial shaved, anything. All righty. So again, test 2. Oh, it's exciting. It is going to open tomorrow. Close on Saturday. So if you have not signed up to take your test, be sure to do that so you can do something crazy like take a test. And of course, study for it. Then it's going to cover the skin, the osseous tissue, which maybe is vaguely familiar because it was just on a practical. I'm sorry, sadness. And then axial skeleton. So you'll have all that information on this test. Questions about what's on it?
Will there be pictures?
Nope. I don't do pictures for lecture, just facts. I like to keep them separated from each other. I don't like my spoons next to my knives. Any other questions? So we have 5 minutes. Your options. You can escape